thank you all for coming for this special occasion. Good afternoon, my dear friends, my dear colleagues, and and my dear students. I will never stop loving educating you about obsessive compulsive disorder. I have been doing it day and night since 1991. And since the first case, I absolutely fell in love with obsessive compulsive disorder. And here I am almost 30 years later. So today I will speak about what it is not, and how to treat it. Obsessive compulsive disorder is the disease of the doubt. It's also called the disease of 1,000 faces, since it always changes its mask and disguise. It is never the same. The fears will start in one area and then go into the other area. It is also has been called it's a disease that hasn't been really recognized as a disease and thought of as a mental illness or psychological problems. However, back in the 90s, we started to recognize that it is actually treatable, that it does have a way to treat it, whereas up until 1966, people afflicted with obsessive compulsive disorder were confined to mental institutions. And mind you, the first description of obsessive compulsive disorder has been written and described in Macbeth by Shakespeare in mid-centuries in guilt-ridden hand-washing in Macbeth, when there is actually no blood on her hands, but she is washing her hands endlessly and feeling the shame and the guilt that is not founded in reality. It was also a disease that has been found in mid-centuries in churches, since this is when they were emerged. Churches were emerged back then, where the thought was considered to be equivalent to the action, and therefore people were punished for thinking a certain way. However, priests themselves finding the writings of numerous writings about OCD, have discovered and noticed that these people who come to confess over and over and over and over endlessly about things that they couldn't have possibly done are writing about it as though it is a disease of a very special kind. I will go back now to the description of OCD. In the DSM-5, it is described as intrusive thoughts, images, and impulses that enter one's mind against one's, causing significant level of distress. Mind you, distress is the hallmark of OCD. Had it not been for distress, there would not be a disorder or a medical illness. Because the distress is so significant, the person is eager to give into the actions that to ward off the distress. And as a result, people end up doing compulsions sometimes 24/7, and that's the kind of the cases we have been seeing both at UCLA and for past 25 years at Westwood Institute for Anxiety Disorders, which has been founded by me 25 years ago. People can be seen as completely bedridden and paralyzed, because it is a sort of a disease of paralysis of the mind. And even though the mind is absolutely brilliant, because most of the people with OCD have above average intellect, way above average than normal. However, while their brain is working brilliantly, they're unable to move because they're being stuck with the thoughts and the actions, because they are unable to shift the behaviors. Compulsions are the hallmark of OCD. There is no other anxiety disorder that is going to have compulsions other than OCD. Remember that very, very clearly. And the compulsions are there only because of the distress and are aimed to balance out the anxiety. But it's an ongoing vicious cycle, demonic cycle, that is actually relieving the anxiety only momentarily, and then in turn causing significantly more distress, more obsessions. I also want to mention that most of us have more than 10,000 thoughts a day, just as people with OCD. And many of these thoughts are garbage thoughts, they're non-essential, and they are also pertain horrific content. However, with OCD, people with OCD are unable to filter through the horrific content and to be able to say that these are garbage thoughts, that they are not essential, and people with no OCD are able to disregard them. Another hallmark of OCD is that is absolutely fascinating, that the thought is equivalent to an action. Usually people say, oh, I'm thinking of this or that, but they are actually knowing that they are not doing it. For example, I'll give you an example. There are times when I would go through red light, let's say, accidentally, when I'm driving a car. And I would say, oh my God, you know, I could have caused an accident. And the anxiety would rise, and I would feel that I'm sweating. But since I passed and the accident didn't happen, I wouldn't have a second thought of this accident occurring. People with OCD would have the entire manifestation of the scene, the accident, the ambulances, hospitals, you know, being paralyzed, being unable to walk, causing distress to the family, causing other family members to get a heart attack, and so on and so forth. They're actually vividly seeing that, where this person without OCD does not, and knows the difference between the action and the thought. The most important thing in OCD is to recognize and to be aware. That's why we're calling this magnificent OCD event today, and the reason we're all here, OCD Awareness Week. OCD Awareness Walk. And these walks and talks are happening throughout the entire America. And I'm very proud and happy to see that it is actually happening, because I was right at the beginning of it all, when there was only one program at UCLA that opened back in 1994 when I was there, and we pioneered it. And then the programs, as Dr. Fo predicted, started opening all around the United States. The idea of this destigmatization of OCD is crucial, because it is a medical disorder that everybody must know. This is not something that is there to be ashamed of. It's not it's not a psychologically acquired problem because of the interpersonal conflicts in the family. It is something that people get most likely because of the genetic predisposition. As a matter of fact, when the studies were done on monozygotic twins, twins that are identical, and they're very rare, the ones that are reared apart, one mother is Chinese and another mother is Russian. So 20 years later, when they tested them, in 63%, mind you, almost 2/3, these two twins were identically afflicted by OCD. I don't mean they had the same fear structure, that they identically washed their hands or they checked. Let me talk about the common obsessions and compulsions. Contamination is considered to be the most common, but contamination can be overt or covert. It can be happening in mind and can be related to the person, place, and geography. And then people think that one thing touching another will contaminate each other. And then they wash hands endlessly. For example, I have had cases where at UCLA I would jump into the showers because to get the person out because they were hitting their head against the walls or their skin was completely removed and not there. They were bleeding, and I would jump in with my clothes to get them out of the showers because the showers were endless. People with OCD usually suffer tremendously, and it is kind of, I don't know of any other disease on earth that can be more treacherous than OCD because it is 24/7. It is always there. It never leaves you. Yet, so I was talking about the compulsions. The next one, and actually maybe the primary one, since it's disease of the doubt, and the doubting disease is the doubt about every single thing, and not being able to make decisions about little things, not such decisions, should I marry this particular bride or not, but it's about which loaf of bread do I buy, or which bank do I go to cash the checks, or which clothes do I wear today. Black and white, white and black, red and yellow, whatever, but they are unable, so they get stuck. OCD, so I'm talking about now the second one, that is checking. Repetitions are very common, repeating behaviors, in and out of door, up and down the chair, and repeating the steps or going over and over. Aggressive obsessions are common. Oh my God, I could have killed this person, I have killed this person. My thought can cause harm to someone, and as a result of my thinking bad, my mother is going to get sick. And there are a zillion different variations that these OCD, aggressive obsessions, and other obsessions can take. With aggressive obsessions come sexual obsessions, which usually cause a lot of shame to the ones that are afflicted by them. But usually, if you find aggression, you find sexual. They go hand in hand, and they can be very scary. Like, for example, molestation of the children, or accidentally molesting someone or touching someone when they didn't mean to. Another one that is collecting and hoarding, but that is a little bit different because it goes also on the continuum of the impulsivity, and they are ego-syntonic, not ego-alien. And they are far more difficult to stop because people are usually don't experience them as the distressful. Always remember that OCD has no component of pleasure in them. It is all anxiety and provoking and distress provoking. So in 1966, after all these people have been confined to mental institution for a lifetime, And believe me, one of the first psychologists in the world who tried to really treat it was Freud. And he was completely correct about the calling OCD a man's disorder, because men usually are considered or were considered to be thinking more, but he was not, and he was correct about, rationalization and thinking and rethinking and over-analyzing. That's what people with OCD do. But he was not correct about the treatment of obsessive-compulsive disorder. So that was in the beginning of last century, and now we are approaching 2020. And if you really think about it, when Victor Mayer, an American psychologist, discovered a treatment for OCD in 1966. And believe it or not, but I was already born at that time. And many of you here were not born, but some of you were. And in comparison to medieval times, and in comparison to Shakespeare times, it is just like yesterday. So this man said he tried 15 people on an inward, and he said, I'm going to expose them, have them face the fears, and block the compulsions. After 15 days of treatment, these people were 75% improved in 75% of the cases. He reported the results, and then everybody in the hospital and then around the United States said, Victor, you're making it up. This is not possible, because for decades, for hundreds of years, people were trying to treat OCD, and they could not. Who are you to come up with such a simple remedy? He said, okay, let's repeat the experiment. They repeated the experiment once, twice, 3 times. So there were 2 people who withdraw, usually, 1 person who did mediocrely well, and 75% improved by 75%. And later, I'm not going to really discuss the whole history of behavioral medicine, which I love to discuss when I talk to residents. But I'll cut it short, and I'll say that later came in Dr. Edna Foa, my mentor, and she said, okay, let me try. Let me try. And when Dr. Foa says, let me try, she tried thousands and thousands of OCs. She called people who were afflicted and calls with OCD affectionately OCs, and now I call you my people, my OCs. You are my people, and I have dedicated many, many years, and as long as I will live, I will continue to do so, to the treatment of OCD. It is since I know how difficult it is to treat. So Dr. Foa came up with the same results, and the results were even better. In her cases, only 25% did not respond. 75% without medications responded to exposure and response prevention treatment. I remember when I studied under her, leaving my 2-year-old son and my lovely husband, who actually let me go for almost 2 years to Philadelphia, to Medical College of Philadelphia, to study under Dr. Foa. And Michael Kozak was my mentor there. When I was leaving, he asked me, so what did you learn, Ida? I said, prolonged and repeated and prolonged. He looked at me and he said, you got it. He said, what else did you learn? I said, assessment, assessment, assessment. He said, you got it again. He said, what else did you learn? I said, they all have to be below clinically significant level. Let me explain what is the below clinically significant level. The cases that I'm describing, you know, when the woman is washing herself for 8 hours a day in the shower, actually, or is unable to get out of bed because she cannot decide which leg to use, the left or right, because you know, getting out of bed are the people who would be ranking probably somewhere 38 on white box, which is extreme, extreme, extreme. And to give you an example, our mean at the Institute is 36, because we're considered to deal with people who have OCD and are very severe. So the teaching was to get all these people under 10, in single digits. So I thought, Michael, you know, it's so simple. To get them under 10, he said, you got it the third time, and then he said, off you go. So I left, and it took me another 3 years at UCLA to do prolonged exposure and response prevention, repeated and prolonged many, many times over and over and over. But to be able to achieve these people, to get them under 10 in single digits, it took me exactly 3 years of very hard work. It's achievable and it's possible. And the research shows that these people then maintain all the gains up to 6 years, and that's without medication. But OCD usually does not come alone. In 50% of the cases, it comes with clinical depression, which is mood congruent ruminations. And these ruminations can be associated with OCD or not associated with OCD. It can be a clinical depression, which is very severe, and then the treatment is counterindicated because they don't have the energy to do it. So it also comes with generalized anxiety disorder in 33% of the cases. It comes with psychosis in about 10% of the cases. It comes with PTSD in about 20% of the cases, and in between 30 and 50% of the cases, it comes with eating disorders in the same package along with the others. Another infatuation that I had throughout my life, other than OCD, is still is body dysmorphic disorder, which afflicts approximately 5 million Americans and is a cousin of OCD, and also is very, very difficult to treat. OCD never comes alone, and remember that all the fear structures must be treated. Let me briefly touch on what the treatment is like. Can anybody give me like a case study, like anything that you want me to resolve for you in a second, like standing up and telling me what you have? If not, I will give you an example. Ruminations are very complicated because they are intertwined and they are mixed up. They're a very good mix with the obsessions and ruminations. They're very similar, but they're very different. Ruminations are usually related to the real life events. It's depression. I will never get up. I will never be able to function par with everybody else. I'm very different. Whereas obsessions are more bizarre, like, you know, for example, you know, this illness is causing my mother to get sick, and my mother will never recover. She will be afflicted by many illnesses because I'm so ill, and now I contaminated my mother. So the characteristics of OCD, and what is difficult with ruminations and obsessions, is to be able to separate the two. It's always difficult to separate, but it's a must, so that we target the correct fear structure. Exposure to the correct fear structure, like for example, I must say that you have been extremely courageous. And you, have been a great trooper. And there is a reason I call you my Amazon, because I know that you will supersede these incredible challenges that you have on your plate, because it's not only OCD, it's also significant level of depression, panic disorder, eating disorders, and all other, how do you call it, mixed, it's a mixed bag. However, I do not believe that something is impossible in this life. What is impossible is when the person usually puts the boundaries and says it is impossible. Then it becomes impossible. I completely take my hat off to you, Em, for being here today. I and Dr. B and Dr. Prilutsky, who is here, and Max, who is here, and our beautiful Gigi, the Olympic champion, who is also here, knows how difficult it was for you to get up and to come here. And I really, my hat is off to you, my darling, and to all of you for fighting and being able to live with this treacherous illness and being able to win. Because every single day that you get up, you are battling the impossible, and you are winning. Because there is nothing in life that is more important than seeing a sunrise and having a full day ahead of you, and making sure that you can make a decision what to do with your beautiful day, and seeing the sunset. Before I end, for 2 minutes, I'll talk about medications. They help only in 50% of the cases, ameliorating 40% of the symptomatology with SSRIs, trial and error, working only at the maximum doses after 12 weeks. With pregnancy and postpartum, we don't know, what are the long-term effects. But once medications are taken away, the symptoms return. So what I want to tell you in closing, that the most important thing is to know that you can do it, and that it is all in your hands, and that your attitude, that every altitude in this life, no matter how high, is decided by your attitude. And Em is a great example of this, because in my wildest dreams last night, I didn't think that I will see her beautiful eyes this morning sitting here in front of me. I thank you all. If you have any questions, let me know, and if you don't, that will be all.